My name is Fazl Bakir. I'm the Surgical Director of the Coronary Center at the Cleveland Clinic, and I'm pleased to be here today with Dr. Donna Kimilarczyk and Dr. Tarek Malas, and we're going to be talking about coronary artery bypass grafting, better known as CABG. We're going to start today by asking a simple question. Can you talk about the symptoms of coronary artery disease?
First of all, patients can present generally with chest tightness or chest discomfort, and that can be a sign of coronary disease. Some patients also feel short of breath, whether it's when they exert themselves or at rest. And some patients don't necessarily have symptoms. And I wanted to pass this to Donna, what your thoughts are about patients who can you have disease without having any symptoms?
Absolutely. So it's a really great question, and the answer is yes. So there's so many patients, I'm sure you both see them too in clinic, and they say, I feel great, or I have no pain, but they're found to have triple vessel disease. And so unfortunately, it does happen. We see folks without the classical chest pain symptoms, especially in folks who have diabetes. I find that they might not experience pain the same way, but there's other patients I see that they tell me, well, I didn't have pain go down the arm, so I didn't think it was my heart, but they've been having very classical angina or chest pain caused by ischemia from blockages in their arteries to their heart. So I always like to advocate that it might not look like the pain you typically see on TV or in movies where it has to be on the left side of your chest, it has to be going down the arm, or it has to be going up the jaw. You can have pain there that just feels like a discomfort or pressure. Some patients describe like indigestion, or they notice pain after eating a big meal. So I think all these are symptoms that folks can experience when they have coronary artery disease.
And it's interesting that women tend to have atypical symptoms.
Absolutely. I've seen a lot of women too. They have maybe pain in the back, or a big symptom that I notice is fatigue.
Right.
They just don't feel themselves. They feel really, really tired.
Well, these are all good tips because there's a whole spectrum of presentation, as you heard. What kind of testing do we typically do at the clinic for patients with coronary artery disease?
So some of the testing that we do for coronary disease is, first of all, we want to take a look at a snapshot of your heart. So first do an ECG, an electrocardiogram, to look at your rhythm. And then for patients with coronary disease, we also want to see, first of all, if we're trying to screen for coronary disease, we do something called a stress test, where we try to stress the heart and take a look at the function of the heart and see if there's any signs of what we call ischemia, or lack of blood flow to certain parts of the blood muscle, the muscle of the heart. And that can be either in the form of a treadmill stress test, or it can be in the form of a nuclear study as well. Before bypass surgery, other tests that we perform are also coronary CT scans to look at the anatomy of the heart. And of course, we want to take a look at the anatomy using something called the coronary angiogram, which is basically where we inject dye into the vessels of the heart. And that gives us a snapshot, super clear picture of the coronary anatomy and where the blockages are. And this allows us to prepare for surgery.
Mm-hmm.
Donna, you do minimally invasive cardiac surgery. Do you want to comment about any additional testing to assess the suitability of a patient for a minimally invasive approach?
Absolutely.
And what do these approaches look like, maybe?
Right, yeah, and so, and I'd like to also put the shout out, you do it too, minimally invasive. So I think the nice thing is we've talked about what tests we feel are important or necessary to see if someone's a candidate for minimally invasive. So in addition to the tests that Dr. Malas has already mentioned, patients will need an echocardiogram, because we want to look at how the heart is pumping, but also we want to make sure there's no major issues with any of the valves inside of the heart. So there's some patients we see that are referred for bypass surgery, and then we do an echo, and they have severe tightness or severe leakiness of a valve that needs to be repaired or replaced. So we'll need an echo, but specifically for minimally invasively, what I've started doing in the last couple of years after talking to you is a CT scan of the chest. So that is so valuable to really show us the anatomy of not just the heart and the blood vessels on the heart, but the blood vessel coming out of the heart, the lungs, the whole space within the chest. So it's really, really important for planning, but also to see if we think someone will be a candidate for bypass surgery minimally invasively. Another test I think is really important is a breathing test, or what we call a pulmonary function test, as you know, and that's going to test to see how strong someone's lungs are. Because when we do minimally invasive bypass surgery, we have to completely deflate the left lung. So you will be breathing just on the right lung for the duration of the surgery, which is a few hours. And so I want to make sure that your lung, the one lung, is going to be strong enough to breathe on its own. And so unfortunately too, I've seen patients where we think, I think I might do minimally invasively, and then I see they have severe COPD or their lungs are very, very weak, and well, we can't do it this way. So that breathing test is very important. And then I also like to do carotid ultrasounds. So I want to make sure that there's no blockages in the arteries that go up the neck, but also that we look at the arteries that come out to the arms. And that's important because the artery that we use for minimally invasive bypass surgery, the left internal thoracic artery, comes off of an artery that goes towards our left arm. And so I want to make sure there's no blockage there, because if there's a blockage in that artery, it's called the subclavian artery, and we take that mammary artery, and it might look great, might look beautiful and perfect bypass, but if there's a blockage in the actual artery that supplies blood to the mammary artery, the bypass is not going to be sufficient. It's not going to work well. So that carotid ultrasound I find very helpful. You also get that same sort of information or good information from the CT scan to make sure there's no blockages there. But those would be the kind of the other tests that I think are really important for planning for bypass or minimally invasive bypass.
Yeah, you obviously do more testing for minimally invasive because the stakes are higher, and you want to make sure that when you go in, there's less chance of a problem and less chance of a conversion to a traditional procedure. You know, this carotid scanning, etc., is probably more relevant in patients with left main disease because they tend to have the predisposition to have blockages in other major vessels. But you're right, coronary artery disease is not a separate island. It's usually part of a spectrum of disease affecting the arteries in the body. One additional testing that we do is what's called conduit mapping. You know, we're going to use bypass grafts, and we want to make sure that we use the best conduits for the bypass, and those conduits or bypasses can come from the chest, from the internal mammary or thoracic arteries that run on both sides of the sternum, and also the radial arteries, typically from the non-dominant hand, which is the left hand, and the veins from the leg. And we don't like any surprises. We want to know the size and the quality of those vessels, so we do ultrasounds to assess the quality, size of those conduits, so that when we go in, we have a perfect planning and we have the perfect combination of conduits for the bypass. Now, we talked about the diagnostic testing, the symptoms. Now, once we're done with the diagnostic testings, who are the ideal patients that meet the indications and should undergo CABG versus who are the patients that are high risk or perhaps surgery is ill-advised in those patients? Tariq, maybe you could start with the optimal patient for CABG in terms of the anatomy of the disease and the overall status of the patient.
Yeah, so that's a fantastic question, and there's a lot of questions from the audience about who is a surgical candidate. Those are all fantastic questions. It's a difficult decision to make. First of all, the most important thing is patients who have blockages in multiple vessels are generally excellent candidates for coronary artery bypass grafting. And we have the left coronary artery as well as the right coronary artery. The left coronary artery divides into the two major branches called the left anterior descending and the circumflex artery. Generally speaking, when you have multiple blockages, those patients fare well with coronary artery disease, coronary artery bypass grafting. In addition to that, patients who have diabetes also benefit significantly from coronary artery bypass grafting. And patients who also have some cardiac dysfunction, meaning their heart is not ejecting normally, benefit significantly from coronary artery disease.
Absolutely. So those are kind of the things that we look at kind of when I'm going through a chart initially, and then as you know, we all then assess in clinic, but also through other past medical history. I want to make sure that a patient is strong enough to undergo a sternotomy, so the incision through the breastbone, if we need to do multiple bypasses, because that's the approach that we take is through the breastbone, if we have to do 2, 3, 4, 5, however many bypasses. So I think that's a really important thing, that looking at a patient's overall health, overall functionality, mobility, and so that you can't always gather from a chart. So I think it's really important to assess in person. And two, I always advocate, and I know we all do as a group, about shared decision making. So really, what are the patient's goals in terms of quality of life, quantity of life, How bad are they affected by chest pains? How bad are they affected by other medical conditions they might be suffering from or being treated for? And how can bypass surgery fit in with that? So I think those would be kind of the big things. And I always talk about the anatomical factors that we look at. So the blockages, the conduits, can I technically and even physically do the bypasses, and then the patient factors.
So yeah, in general, when patients have multi-vessel disease, CABG is recommended. When they have the left main disease, that's also another strong indication. But also when they have complex anatomies, even for a single vessel, we would do bypass surgery with an option of a minimally invasive robotic-assisted approach. We have, I mean, surgery is very safe. CABG is very safe. We hardly ever turn down a patient for surgery unless, for example, they have extreme forms of disease, such as a bad liver, like advanced liver cirrhosis, or really bad lungs. Those are the patients where we need to think twice about offering surgery. Age is not there's no absolute cutoff. We've done octogenarians, we've even done patients well into their 90s with good outcomes. However, there are other options for patients who are too frail or too sick for surgery. Donna, perhaps you could shed some light on those other options that may be available.
Yeah, so whenever I see patients and we're talking about surgery or we're talking about blockages, I always say there's kind of like three main pillars of treatment or three options. So surgery being one of them, so bypass surgery, stents as another option, and then medication. So I kind of break it down into those three categories. And so if we feel that surgery is not an option for a patient, then it kind of leaves us with looking at stenting, and I say and or medication. And I always say too, whether someone is going to have stents or surgery, you're still going to be on medication. So I say surgery or stents are not
That's
a way
an
to get,
important point, yes.
absolutely, you're not going to get off the medication. Like I said, those really help the bypasses and help the stents. So medication is kind of always there in the background, but then it really, I think, comes between stents or surgery.
Tarek, what's the difference between a stent and a bypass?
So that's a great question. Two different approaches. One is a transcatheter approach, and one is an open heart or generally a surgical approach. A stent, we usually go through the coronary arteries, the native coronary arteries themselves, and we blow up a balloon and place this metal frame inside of a blockage, and that reopens an artery, and that's done in the cath lab by interventional cardiology.
Usually like through the wrist or through the groin with those little needles. Yeah.
Exactly, and those are done through wires and catheters, and it's generally a less invasive approach compared to open heart surgery. And with open heart surgery, what a bypass is, it's like a detour in the road. That's the way I think about it. We don't usually touch the blockage. We usually add a secondary circulation after the blockage, and that helps optimize blood flow to certain parts of the heart that are not receiving blood, and that's basically what a bypass is. Whether we use arteries from the chest wall, the arm, or veins from the leg, that supplements the circulation.
That's an excellent explanation, because many patients tell me, what are you going to do with the blockage? I say, well, we're going to bypass it. You don't have to worry about the blockage. So the stent is a local treatment. The bypass is just adding an additional route beyond the blockage. And that's why we pay attention to the technical aspects of surgery and the durability of the bypass conduit. Because if you put a durable conduit there, that should stay open in perpetuity and protect the heart from future blockages, whereas a stent treats that blockage and that's it. So, and another difference between the modalities of treatment, the PCI and the CABG, is that the PCI tends to be a really good choice in patients who have an acute infarction, especially what's called ST elevation infarction, where they come in with a blocked vessel and they're in the cath lab and they're doing a diagnostic procedure and they find a blockage that's causing the heart attack. If it's technically feasible, then they could put a stent in that acute setting, and that works pretty well. In the chronic setting or the stable setting and in multi-vessel disease setting, CABG tends to be the modality of choice. Okay, so we've decided that a patient is a surgical candidate from an anatomy standpoint and they can tolerate surgery. Now we're going to talk through how we proceed with traditional. Let's start with traditional CABG. Maybe you could start with that, Tarek, and then maybe Donna could talk about the robotic-assisted minimally invasive approach. Explain to our patients how we do the bypass surgery in the OR.
So Dr. Bakin gave a fantastic overview about what we do when we assess a patient. It's a complex decision that's made between the patient and the physician. And after a lot of extensive testing and to know that the patient's finally a candidate, then the next step is taking to the operating room. And in a majority of cases, coronary artery bypass grafting, especially if multiple grafts, is done through a sternotomy. And a sternotomy is basically an incision in the center of the breastbone, and that allows us to access the heart. Once we have access to the heart, we can visualize the vessels directly on the heart, and the next step is to bypass the arteries that require bypass. And that can be done through two different approaches. That can be done with the assistance of something called a heart-lung machine, which is a machine that supports the heart and the lungs and that allows us to do some bypass. And that can also be done in an off-pump setting, meaning we can do surgery actually on a beating heart, and that's a fantastic operation as well. And what we do is we basically attach these grafts or conduits to an area of the artery that is past the blockage, and that allows us to supplement the circulation. And bypass surgery can range from 1, 2, 3, 4, 5 bypasses or more, and that really depends on the anatomy, the conduits, and the type of disease that the patient has.
What conduits do you prefer in general, especially for younger patients or patients with prolonged life expectancy?
We are a strong advocate of multi-arterial grafting here at the Cleveland Clinic, and what multi-arterial grafting means is using more arteries than veins, and there's strong evidence that suggests that arteries last longer than veins, especially, and the most important artery is the left internal mammary artery that sits on the underside of the sternum. There's significant evidence that shows that really prolongs life, and there are two arteries in the chest wall, and we prefer to optimize use of multiple arteries, even in the radial artery in the arm, over using conduits such as veins. And if you look at national data, not many centers do a lot of multi-arterial grafting, and we should be definitely more of a proponent of that. And that's something that we hold very dearly here at the Cleveland Clinic, that shows that multi-arterial grafting actually improves survival on the long term for patients.
It really started here with Dr. Loop back in 1986, where he published a seminal article in the New England Journal of Medicine showing that if you use an internal thoracic or internal mammary artery, that stays open in perpetuity and prolongs the life of the patient, and became the gold standard when you perform CABG, coronary artery bypass grafting. And then after that, Dr. Lytle in the late 90s demonstrated that if one is good, then two must be better, and he was absolutely right. So in many of our patients, the default approach is to use multiple arteries. So this is the traditional approach that we offer to patients, but there are patients who are suitable for a minimally invasive approach. And you talked a little bit, Donna, about what kind of workup you use.
Right.
And once you determine that the patient is a suitable candidate for a minimally invasive approach, talk us through how you do it.
Right. So when we do a minimally invasive approach, it's what we mean is it's a small incision. I say usually about the length of a credit card that's on the left front of the chest, and I say it's usually under the areola in a man or a woman, it's just kind of above the inframammary fold. And that through that cut, that's where we actually do the bypass.
It's right underneath the breast.
Right underneath, yeah, for a woman. And then so that's where we do the bypass. And how we've also, you and I have done this before we had the robot, through that little cut, we would actually detach, or I say sometimes peel off the left internal mammary artery off of the rib cage through that little cut. So it's very technically, I think, demanding, because I always tell people you're working through a little hole and like a little tunnel. You're working down here, you got to get all the way up here to get that artery down. So I still do that approach, or you still do that approach if indicated, but with the robot, what makes it a bit easier is there's better visualization, as you know. But in order to use the robot, we then have to make 3 separate little incisions, usually about 1 centimeter or so in width, so that we can actually get the arms and the camera of the robot into the patient, so the robot can, or we can work the robot. And so those 3 incisions are on the far left side of the chest between the ribs. And you're usually a couple rib spaces apart between each of those 3 cuts. And so you have those 3 small cuts on the far left side of the chest, and then your slightly bigger cut on the front of the chest on the left side. With those 3 incisions, you're able to do that minimally invasive bypass.
So basically, 3 keyholes. The
Yes.
middle one is for the camera,
Yep.
and then 2 working ports, one above and one below it, and you're taking down the vessel. The advantage of the robot is that you have enhanced visualization, you have 10 times the magnification,
Yes.
so there's preciseness, there's accuracy, and perhaps there's less spreading of the ribs, because when you take it without the robot, you have to spread those ribs to see and take it down under direct vision. So you could take a longer mammary, internal mammary with the robot. You could spread the ribs less, so you cause less pain. And then once the mammary is down, you actually do the actual sewing with your own hands
Yes.
through that credit card incision that you made.
Yes.
Mine might be a little bit more than the credit card. It depends on the size of the
Depends
patient.
on the
bigger
patient.
patient will need a little
A
bigger
little
hole.
bit bigger, yeah.
The benefits of robotic surgery are incredible, because it's such an incredible tool, because like Dr. McKean said, the magnification is superb. You get to view the robot very well, and there are these 3 slender tubes that go in between the ribs, rather than having to do, for example, any bone cutting. We don't do that in robotic surgery, and that really improves the recovery of the patient and has a fantastic cosmetic result as well.
And when you do the bypass, you do it with the heart beating. You don't go on the heart-lung machine.
Correct. I do it
Neither
with the
do
heart
I.
beating.
Yes.
I think, talking with other folks across the country, that
Yes.
tends to be, I think, most common that we do with the heart beating, because the nice thing about doing that one bypass to that left anterior descending artery, so that's really the artery that we're treating, it's right on the front of the heart. So it's usually right under where we've made that incision, so we can see it very nicely. And I also do sternotomy approaches without the heart-lung machine majority of the time, so that's also why I do this minimally invasive without the heart-lung
So
machine.
the heart is beating like that, and you're going to sew on that vessel. How do you do that with the heart doing this?
Yeah.
I know how to do it, but tell our audience.
So there's specific tools and instruments made to facilitate working on a moving target that also has blood being pumped through it. And so once we have taken that mammary artery off of the rib cage, you then what's called undock or take out the robot. You don't need it anymore, because now we're going to sew the actual bypass by hand. And so then through one of those holes that you made, you can put this stabilizer device. And so it's 2 little arms that have suction on them that you then place onto the heart on either side of the blood vessel that you're going to sew onto, right in the area that you're going to sew onto. And so the whole heart's moving, but because this little suction device is attached to the heart, this part of the heart moves a little less. So it makes it a little bit easier to sew onto that moving target. And then there's sutures that we can use to temporarily occlude blood flow through that artery when we open the artery to actually sew onto it, so you don't have as much blood coming through it. And then what my practice is, and I think a lot of other surgeons' practices that do this beating heart, is we put in this something called a shunt. So it's a very small little plastic tube. They're very, very soft, and they come in different sizes based on the size that's going to fit that artery. And through the opening that you've made on the artery where you're going to actually sew your bypass, you then insert the little shunt proximally, so before the opening, and distally beyond the opening. And then you can remove the sutures that is occluding or closing off that artery. So now it's pretty cool. You have blood flow going through your coronary artery, through that little plastic tube, it's like a tunnel, and then continuing on distally to the remainder of the artery. And so you have blood flow going through it the whole time as you're doing the bypass. And I think it's very, very safe because you're getting blood flow to that whole part of the heart. I sometimes say it's almost like the heart's none the wiser that anything's going on. And I just sew, and you guys too, just sew around that little shunt as I'm doing my sutures to sew on my artery onto the heart for the bypass. And then right before you're done your last suture, you can pull that little shunt. It's very soft, as I mentioned, so it comes out nicely, and then you tie down your bypass. So there are specific tools that are made to make it a little easier.
So it has to be perfect. I know that you're a very skilled surgeon and you take perfect bites, but how are you 100% confident after you finish sewing this in a traditional and a minimally invasive approach that this anastomosis is actually perfect?
Yeah, so we are big proponents, the three of us, of using that ultrasound probe.
Yes.
And so there's a little ultrasound probe that can actually measure the flow through the bypass and also the resistance through the bypass graft. And based on the flow, the actual milliliters per minute, and the resistance, that will tell me if I'm happy with the bypass, if it's an excellent bypass, or if I'm concerned about it and I should redo it or adjust something. So I think that's really been a fabulous tool, a very helpful tool.
So hopefully if you chose your conduits well and you did a technically perfect operation like we always do, you should have good short and long-term outcomes. And talking about outcomes, Tarek, perhaps you could shed some light on the major outcomes that we look at in cardiac surgery, especially CABG.
That's a great question. So we have, some of the best outcomes in the country, and the reason was we're so, we're pressed on always looking at the details of the operation and doing a technically good operation, choosing the right patients as well. So some of the major outcomes we look at is both, first of all, survival in the hospital and also long-term survival. And that's very important for us. We follow our data and look at our patients and how well they do. Other outcomes that we look at are in the hospital. We look at the risks of strokes and the risks of heart attacks. And we also look at other outcomes that involve secondary outcomes. So for example, looking at do patients have, risk factors with regards to things like pneumonia or being on a ventilator. We also look at things like looking at kidney disease, if patients have, some kidney dysfunction after surgery. And we track a lot of these. Other things that we track about include bleeding after an operation, and these are data that we track very efficiently here at the Cleveland Clinic, and we always look at our outcomes to look and compare that to the national database.
Yeah, I mean, to have great outcomes, it really starts from the beginning. As we said, the patient workup, the heart team approach with our cardiologist, optimizing the patients, selecting them appropriately, and going through a technically perfect, expeditious operation, and then the outcomes will follow as anticipated, will be excellent. We have had less than 1 in 100 deaths, despite the high complexity of cases that we do. So less than 1% mortality for many, many, many years now. And I mean by highly complex cases are those with severe heart failure, patients on mechanical heart support, or transfers from other centers because they were technically too demanding. And we also do multiple reoperations, meaning that the patients have had surgeries elsewhere and now they need another operation, second, third, or fourth operation. So despite all those complexities, the death rate is less than 1%. And if you take a healthy person that comes for elective CABG, the death rate is 1 in 1,000 or less. So it's a very, very safe operation. The risk of stroke, kidney failure, external wound infections are really, really low. They're less than 1%. Again, thanks to the multidisciplinary approach for the perfect surgery and attention to details. So once they have undergone the surgery, now is the recovery time. So let's talk about the recovery time for a traditional and a minimally invasive CABG. Let's start with the traditional, Tarek.
Yeah. So open heart surgery is definitely a big deal for patients. It's a big life event that definitely requires some recovery. And that's where, the benefit of minimally invasive surgery is. Now, when we talk about a traditional open heart surgery, the biggest item that requires recovery is really just the healing of the bone. I tell my patients, you're going to be able to walk and push yourself from day 2 after surgery. I'm going to push you to walk and continue to do your activities. My hope is that your limitation will be your breastbone and not your heart, and that's generally what I tell my patients. The breastbone, because it is a fresh incision in bone, like a fracture in a bone, it takes a few months to heal. So what we advise our patients is generally to avoid lifting something more than, say, for example, 15 pounds for the first few months until that bone heals.
Oh, you're very restrictive here. That's what many pamphlets put. I have an experience in a family where a octogenarian broke a hip. They operate, stabilize the hip, and have them walk right away. And as Tarek said, we have them do aerobic activity right away. That sternum, when closed appropriately with wires plus or minus plating, is pretty sturdy. The bone doesn't have to be fully healed before they can do activities of daily living. However, we want to avoid strenuous exercise and extreme lifting. So you mentioned 15 pounds. I think that's a little bit too conservative. I tend to use 50 pounds. What about you, Donna?
Well, I'm ultra conservative. I would say for the first 4 to 6 weeks, nothing more than 10 pounds.
Okay.
I'm very conservative.
Well, this shows that there's a difference in opinion, because I know that other staff at the clinic follow my approach,
Yes.
and therefore we're actually about to evaluate this in a randomized trial to give the perfect advice for our patients. But my more liberal strategy has not, in my experience, contributed to any issues, but that is something that deserves further study. Now, the minimally invasive approach is probably a little bit more liberal, right?
Oh, yes. So that's really the big advantage of minimally invasive, is the faster recovery. I say there's no difference in the quality of the bypass. That should be exactly the same, but it's really the recovery time shorter. So I say as soon as you're feeling up to doing activities, do it. Because yes, it's minimally invasive, but it's still surgery. I said those first few days you might be a little tired. You might be a little sore. You might not feel like swinging a golf club yet or doing activities, but when you're feeling up to it in a week or two, you can. Yeah.
So the length of stay in the hospital, many people ask, on average 5 days at the clinic. And I'm sure, Tarek, you've had patients who are ready to go home day 3, but some patients a little slower, little issues, may take a couple of extra days. But in general, would you agree that 5 days for a traditional approach? And maybe, I've had minimally invasive patients that would leave the same or the next day, but I've kept them an extra day just in case.
I do like 2 to 3 days
Okay,
after
that
minimally
sounds
invasively.
reasonable. That sounds reasonable.
Yeah.
Now, some patients get post-operative atrial fibrillation, which is not dangerous. That can prolong the length of stay a little bit longer. So that's good. So we talked about the spectrum of care from workup to surgery to post-op care. You emphasized the medications. What about secondary prevention? What do people do after they leave the hospital and longer term to optimize the long-term outcomes?
Right. So there's certain medications that I say that you should plan to be on these for life. So that baby aspirin, one of our best friends, that really helps with bypass grafts. In certain patients, as I think a lot of the surgeons here will do too, you might go on Plavix as well for a period of time to help with the bypass grafts. I tell patients the things that you're told before surgery to be healthy and heart healthy, we're still going to say after surgery. So making sure your blood pressure is well controlled. So you might still need to be on blood pressure medications, beta blocker ideally in those early months after surgery. That I say keeps kind of the heart not stressed out, because it keeps it a little slower, so it doesn't have to work so hard. Before surgery, you probably would have been talking about making sure your cholesterol is well controlled, and triglycerides is going to be the same thing after surgery. And also these statins, I think, have been shown to help with patency and longevity of the bypass grafts as well. So secondary prevention is huge, and is really, I think the improvements we've seen in medications are what have also helped the long-term patency of some of the grafts.
Atherosclerotic disease is going to continue to progress, and it's not something that you stop. What we can do is slow it down by controlling those risk factors. Say, for example, controlling diabetes, controlling blood pressure, cholesterol, things that actually progress. And the coronary disease actually progresses in both the grafts, the stents, and the native arteries, and that will continue to progress. So what we do is, by controlling the risk factors through secondary prevention, we can actually reduce the progression of the disease and improve long-term outcomes.
So we do our part as surgeons, but you, the patients, need to do your part, and we can help you do that. Now, this has been a fascinating discussion. We covered CABG, coronary artery bypass grafting. What we didn't talk about are treatment of coronary aneurysms. It's when the vessel enlarges in size, and this can cause complications and heart attacks. We didn't talk about anomalous coronaries, meaning coronaries that come off a different than normal takeoff and pathway around the heart. These are topics for further discussion, but we offer specialized care for those patients because these are uncommon scenarios, and you need a center that's experienced with higher volume patient load to address those anomalies and pathologies effectively and safely. Thank you very much for joining us, Dana and Tarek. This has been really excellent. I've actually learned something today. I hope you enjoyed this as much as I did.
Yes.
Thank you
Yes.
very much.
Thank you very
Thanks so
much.
much.